Hello, I'm Larry Holden, President and CEO of the Global Liver Institute and your host for the Global Fatty Liver Day. Today we are bringing together leading voices in hepatology and physical therapy to shine a light on the metabolic dysfunction associated steatotic liver disease, or MASLD, one of the fastest growing yet least understood chronic conditions. Through this conversation, we aim to raise awareness, improve the understanding of risk and disease progression, and highlight both emerging treatments and the critical role lifestyle interventions like physical activity play. And now I'm pleased to welcome Dr. Ritonya Carr from the Association of Black Gastroenterologists and Hepatologists, who will be leading today's conversation. Dr. Carr is a Cyrus E. Rubin Chair in Medicine and Division Head of Gastroenterology at the University of Washington. She's a hepatologist and co-founder and board member of the Association of Black Gastroenterologists and Hepatologists, and will be moderating this session today. Dr. Carr.
Thank you, Larry. I'm thrilled to be here again representing the Association of Black Gastroenterologists and Hepatologists, or ABGH. ABGH is a 501c3 organization whose mission is to promote health equity in Black communities, advance science, and develop the careers of Black gastroenterologists, hepatologists, and scientists. Today, we are here to have a conversation about metabolic dysfunction-associated steatotic liver disease, MASLD for short. It used to be called fatty liver disease. And we're also going to talk about the available treatments. Not only the medications that are available, but also how exercise itself can help treat this disease. And so we ensure we get this information out as far and as wide as possible. We will share this session on both the GLI and ABGH websites and social media channels after this airs. So let's get started. Today you will hear from two physicians and a physical therapist, and I am excited to introduce these panelists to you. With me here today are Dr. Ashley Spann, who is an assistant professor of medicine in the Division of Gastroenterology, Hepatology, and Nutrition at Vanderbilt University Medical Center. She holds a secondary appointment in biomedical informatics and serves as Director of Clinical Research Informatics for the Gastroenterology Division. She's also Associate Director for Transplant Research Informatics for the Vanderbilt Center for Transplant Science. Her research focuses on leveraging informatics methodologies and artificial intelligence to improve care for patients with chronic liver diseases. Dr. Tinsay Wareta is an associate professor of medicine in the Division of Gastroenterology and Hepatology at the Johns Hopkins University School of Medicine. She's currently the program director of the Gastroenterology Fellowship there, and her clinical and research interests are focused on the diagnosis and management of patients with MASLD. We have also Dr. Nicole Dugan, who is a physical therapist and an APTA board-certified women's clinical specialist. She is currently the clinical program leader for pelvic health for Jefferson Moss McGee Rehabilitation in Philadelphia. Her current research and clinical treatment focuses around pelvic floor-related dysfunction for all gender patients. And while not a panelist per se, we have a volunteer, Ms. Nadine Durham, who will be working with Dr. Dugan to show us some exercises today. Welcome, everyone. I think I would like to start today's conversation with you, Dr. Spann. How are you doing?
I'm doing all right. Thank you for having me here today.
Yeah, I'm excited for the conversation. So you're a transplant hepatologist and you specialize in the care of patients with MASLD. Before we get into the disease itself, MASLD, I think it's important for everyone listening to understand exactly what the liver is, maybe where it is, and a little bit about what it does. Can you share?
Yeah, absolutely. The liver really is the powerhouse of our body, and it does so many different functions that we need to have on a day in and day out basis. And it just sits just right underneath our rib cage on the right side of our body. And it does a lot of different things for us. Many of those are shown here on the slide. And these functions allow us to move in, day out, and continue the things that we need to do. One of the concerns, though, is when you start to develop liver disease, you lose the ability ability of your liver to really act as the factory of your body. It stops making these proteins, it stops filtering out these toxins. And when that happens, you really lose the ability to manage those functions. You start to develop swelling, you can develop confusion related to liver disease. You may even notice yellowing of your eyes or skin as a result of that.
So the liver is very important. I really appreciate you for kind of laying the groundwork for us. And we've been talking just a little bit about this condition called MASLD. So can you talk about what that is, reflect a little bit on the name change as well, in case our viewers have never heard of it?
Absolutely. So, as you mentioned, we have this new name for this condition that's been around for quite some time. It's now called metabolic dysfunction associated steatotic liver disease, formerly called fatty liver disease. And there were many reasons for why we wanted to make this change in the name, but we really wanted to focus more on what is the underlying factors that are driving this liver change. And it's really about the ability of your liver to manage the metabolic functions are no longer present as a result of this condition. It leads to fatty infiltration in the liver, which may be called, or you may hear the term steatosis. And that steatosis can potentially lead to inflammation. If that inflammation persists, that can lead to things like liver scarring or even cirrhosis, which is end-stage liver disease.
So how common is it and who can get it?
Honestly, anybody is at risk for this condition. This affects all races, this affects all ages, this affects all genders as well. We can see this in as many as 1 in 3 adults, and this can also be seen in our children too. 1 in 10 children may have this condition. And it's really important to know that with this condition, you may not have any symptoms associated with it whatsoever. So many people are walking around with MASLD and have no idea about it.
So you talked about a very serious condition, something that can start from a little bit of fat accumulating in your liver. People can get cirrhosis from this, but then they don't feel it. So that sounds very worrisome. How do folks know if they have it, if they're not having symptoms from it?
Yeah, absolutely. And one of the things that, worries us hepatologists, us liver doctors, is that all these patients are and these people are walking around with this condition, have no idea about it, have no symptoms until they start to experience the failure of that factory and all those symptoms have started to come up at that point. But we really want to be in a position to where we can identify who these patients are so that we can get them to treatment sooner. And really, the people who are at the greatest risk for this are those who have a lot of metabolic risk. So these are patients who experience obesity, who have diabetes or prediabetes, high cholesterol, high blood pressure. All of those things put you at increased risk of having this condition. And if you have any of these, it is certainly important to ask your doctor to be screened for liver disease.
So I know you do a lot of research on this. What can we do in the health system to try to find people, because they don't have symptoms? It could be very severe. This is a big problem.
Yeah, absolutely. And one of the things that we can see in people who have this condition is that finding of that fatty infiltration of the liver on an imaging study. More often than not, people may get imaging studies for other reasons, and this finding might show up on their scans. One of the issues with that, though, is if it's not being well recognized, how do we bring that to the forefront so that we can identify them sooner? A lot of the work that I do is using the data that we have in our electronic health record systems about all of our patients to get a sense of what their levels of risk are so we can bring that awareness to our providers who are taking care of them. So a lot of, I think, work needs to happen such that we can use the data that we already have to
Mhm.
identify who these patients are who are otherwise being missed.
Well, I'm glad you're working on this because it's a big problem. And yeah, we need research like yours to really find these patients. So thank you for doing that work.
Absolutely.
Dr. Loretta, I'm going to move to you now. So we know what the disease is. We know that it can even progress to cirrhosis and people developing end-stage liver disease from this. So what can people do about this disease so those things don't happen to them?
Great question, Dr. Carr. Once it's important to know that once someone has a diagnosis of MASLD, it's very important to implement lifestyle changes to prevent it from getting worse and can even help reverse it. Lifestyle changes to achieve 10% weight loss over 6 months has been shown in many clinical studies to decrease fat in the liver, to decrease inflammation, and can even reverse fibrosis. And we actually have the best evidence for the Mediterranean diet as the most effective diet for the treatment of MASLD. And so this is a diet rich in fruits and vegetables, lean protein like chicken and fish, and low in saturated fat and limited in carbohydrates like bread and pasta. It's also very helpful to do moderate intensity exercise on a regular basis, so at least 30 minutes a day, 5 times a week. It's also very exciting that we actually now have 2 FDA-approved medications for the treatment of MASH. And so the first is called resmetirom, which was approved in March 2024. Brand name is Resdifra. And you take it at a dose of either 80 or 100 milligrams based on your weight. And it's a pill that you take once daily. And the second is semaglutide or Wegovy, which was approved in August 2025. And this is a weekly injection of a dose of 2.4 milligrams. So both are now approved in conjunction with diet and exercise for the treatment of patients with NASH with stage 2 to 3 fibrosis. So diet and exercise is still the backbone of treatment, but we now have medications that we can add to them to also help.
You mentioned the word fibrosis in stage 2 to 3. What does that mean?
Yeah, that's a good question. Yeah, so as Dr. Span was saying, inflammation in the liver can lead to scar tissue, which is what we call fibrosis, and we stage it as stage 1 to 4. So with stage 1, it's just a little bit of fibrosis in the liver. And with stage 4, that's the end stage scarring that we call cirrhosis. So 2 to 3 is that intermediate stage where patients would be at risk of progressing to cirrhosis if untreated.
So you have a couple of graphs here. Can you tell us about these studies that have been done?
Yes. So I mentioned the 2 new FDA-approved medications since 2024, which is very exciting that we're able to actually now have medications that can be used in addition to counseling with a lifestyle intervention. So the 2 medications, you can see these are the clinical studies that led to their approval. And the clinical studies really show that both medications are very effective and overall very well tolerated. The first graph, you'll see the clinical studies of resmetirom, and you can see with the dark blue graph that about a quarter of patients who received resmetirom achieved fibrosis improvement compared to only 14% in the placebo group, and both groups did receive lifestyle counseling. With semaglutide, that's the second graph that you'll see to the right, you can see 36% had fibrosis improvement compared to only 22% of patients receiving placebo. So it looks very effective and in an important outcome of actual fibrosis improvement.
So both of these are possibilities for treatment for patients with MASLD. Do you use these in your own clinic?
Absolutely. So once we identify a patient that has stage 2 to 3 fibrosis, we consider them for initiation of treatment. And we can, liver biopsy previously was the gold standard, but now in clinical practice, we're rarely doing that. So we have non-invasive ways, either through ultrasound or MRI, in identifying a stage of fibrosis. And yes, that would be an indication for starting treatment.
That's really good news that most patients don't require a liver biopsy anymore. I'm really glad that those days are almost behind us for most individuals. So we have these 2 drugs. Can you share a bit about how they work and which patients do you think are good candidates for the different therapeutics, and maybe talk a little bit about the side effects too? I know patients are always wanting to know if they're going to add something. What are the things to look out for? Is it safe? Are they going to experience any other symptoms?
Absolutely. So I'll start with resmetirom. So resmetirom works on the thyroid hormone receptor beta expressed in the liver to reduce liver fat and inflammation. So it is liver directed. Semaglutide is a GLP-1 receptor agonist. It works by acting like a natural hormone in our body called glucagon-like peptide 1. And it targets areas of the brain that manages hunger. So it causes you to feel full more easily and have less cravings, which can help you eat smaller portions and help you lose weight. It can also help lower blood sugar levels by helping the pancreas release more insulin in response to high blood sugars. And it's already approved for weight loss and diabetes management as well. So if once we identify a patient with MASH with stage 2 to 3 fibrosis, we consider them for initiation of treatment of either of these medications. And we can talk a little bit about how we decide which one to start.
Yeah, why don't you share like how do you decide, and then maybe we can get into the side effects after that.
Yep. So we do make the decision on which therapy to start based on whether a patient has other medical conditions, such as being overweight or obese, or whether they have diabetes. So that's all important to consider. So for example, if I have a patient who has overweight or obesity, and they have what we call metabolic syndrome, which is insulin resistance with either prediabetes or diabetes, and they may have other medical complications of obesity, such as sleep apnea, then I prefer to start the GLP-1 analog semaglutide, because that way you can help the patient lose weight and reverse many of the other medical conditions that are associated with being overweight or obese. On the other hand, if I have a patient who's near normal weight and they don't have diabetes, I consider starting resmetirom because, as I mentioned, the effects are liver directed and can really decrease inflammation and fibrosis. And if you start one, it actually does not mean that you can't start another medication at a future time. And in fact, in the clinical trials of resmetirom, 20% of patients were taking the GLP-1 receptor agonist, but they had to be on a stable dose for 6 months prior to starting. So my practice is, if I start a patient on a GLP-1 analog because they have overweight or obesity and associated medical conditions, and once I have them on a stable dose for 6 months, I'll recheck the fibrosis stage. And then if they have evidence of stage 2 to 3 fibrosis, I will start resmetirom in addition to the GLP-1 analog. So
I was just going to ask if you can do them in combination. So that's really exciting to hear. So we have 2 separate options, but even some patients can be on both if needed.
Absolutely.
What about side effects? How do patients tolerate these medications? What do we have to look out for?
That's a good question. So the most common side effects of both medications are actually GI side effects. So with resmetirom, the most commonly reported side effects that we saw in clinical trials were diarrhea and nausea. But the good news is that most cases in clinical studies, they were only mild to moderate in severity, and it rarely led to people having to stop treatment. Resmetirom can also cause elevated liver enzymes, so we do monitor liver enzymes after starting treatment. Less commonly, gallbladder problems have been reported, such as gallstones or inflammation of the gallbladder. So if you develop right upper quadrant pain after starting treatment, then you definitely should inform your doctor, because that has been associated. Semaglutide most commonly can cause nausea, diarrhea, constipation, or vomiting. So again, it's the GI side effects. However, we do start at a low dose and gradually up titrate, and that tends to decrease the side effects and make it more tolerable. Most side effects are actually mild as well, and again, rarely leads to people having to stop treatment. Because semaglutide can lead to significant weight loss, it can lead to muscle loss. So that's something we monitor for. And rarely it can cause pancreatitis, gallbladder problems, and vision changes.
So these medications can get started. It seems like overall very well tolerated. And, the good news is that I'm hearing that MASLD is not a death sentence. I can't tell you the number of times patients come into my clinic with, having been diagnosed with this, and they are in literal tears because someone has told them that they are going to die. And they are really feeling a lot better by the end of their time with me, having gone through, what's available. So are you saying that with diet and exercise, and if these medications are warranted, that patients can improve their liver disease, Dr. Loretta?
Absolutely, Dr. Carr. And we have many clinical studies showing how effective lifestyle interventions with diet and exercise can be in reversing MASLD. And now we have 2 FDA-approved medications that we can start for patients with fibrosis to reverse that. So this is certainly a reversible disease at the earlier stages. So I know it can be terrifying for patients, but it is reversible.
Well, that's good news. I would end there, except that, a lot of the things that you mentioned, which are the cornerstone of how we care for this disease, are lifestyle based. And while this is all really great news, lifestyle changes are really very hard. I think we probably all have those stories, and especially exercise, because it's not really clear to a lot of people, even to us as healthcare workers, what exercises to do, how much to do. Do we need to do it every day or some days? We heard, one recommendation earlier, but is that the only recommendation? So, Dr. Dugan, I'm now going to turn to you because you are the only expert on this panel in this space. So, what else can you tell us about the role of lifestyle changes in MASLD?
Thank you very much for having me. This is great to have the opportunity to promote the mainstays of the treatment for MASLD, which is exercise and nutrition. So last year you had a great talk about nutrition. So I want to briefly talk about that first, because you need nutrition. Nutrition is the energy to fuel your body so that you can exercise. So Dr. Loretta talked about even if you go onto one of these medications, you have a decreased appetite, but you still need to be eating the right things. So the basics of nutrition are still not to be ignored when we're thinking about exercise, which is the fuel for your body.
So the nutrition piece may be a little easier to understand. I heard the Mediterranean diet. People can kind of look that up, see what that is. And by the way, for those of you watching today, shameless plug, we did a session last year on MASLD and nutrition, so with a nutritionist. So please do check that out as well. But anyway, just coming back to today's conversation, nutrition may be a little easier. People are familiar with different diets, but the exercise part is harder. I definitely have trouble teaching my own patients what to do. So
yes.
Can you share a little bit more about that?
Sure. So the research really is that 150 minutes of moderate exercise per week is the minimum that we all should be doing as a society. And guess what? The research is for MASLD that those guidelines still are recommended. So we had a suggestion of 30 minutes, 5 days a week. Not everybody has 30 minutes, 5 days a week. You could do 50 minutes, 3 days a week. You could do 25 minutes, 6 days a week. So my graph here really just says it doesn't really matter how you slice it up. You need to get in your 150 minutes. For some people, actually, even doing 2 sessions of 10 minutes per day can bring them up to their time frame. So they might have a day where you can't put in your 25 or 50 minutes. And so I don't need to go through every math equation, but really when you get up to it is however you add it up through the week, get in 150 minutes of aerobic exercise. And then the bonus is strength training. We saw one of the side effects for taking the GLP-1s is muscle loss. So we need to be able to protect the bone and the muscle, and that's with the strength training addition to the aerobic.
So I really like this menu of options for exercise. Our lives are so busy. It's hard to do the same thing every day. But I honestly, this is the first time I've heard that we can divide it differently. So thanks for sharing that. The magic number is 150. Okay, as long as we get there, that should suffice. But hearing about it and seeing it, 2 different things. So I'm hoping you can show us a little bit today as well.
Absolutely. Yes.
What do you have for us?
All right, so on the next slide, I actually just wanted to say we had our focus of being on aerobic and strength training. So we're going to go through those examples in the time that we have for this webinar today. I did want to just also add in bonus. Bonus is balance and flexibility. So we're going to demonstrate a couple exercises, and I'm going to say a couple of things about balance. But one of the factors that we talked about as far as being at risk for this MASLD is of diabetes and obesity. And oftentimes what happens with diabetes along with the liver is we have things like balance and flexibility being impacted. So getting the whole range of exercise is important for us. So with that being said, let's get into some demonstration for aerobic and strength.
All right, so we're going to get set up. And is it okay if we ask you questions in the middle? Like, I'm sure I'm going to have some.
Yes, please ask questions as we go along, because this is meant to be user friendly for everybody who is who's logging in.
Awesome. And we welcome Nadine again. Thank you so much for volunteering to show us some of these exercises. Dr. Dugan, you just let us know when you're ready. I think it's great that you're doing this in the home setting, because that's where most of our time is, and it's hard to get outside and go to a gym. So I really appreciate that choice today.
Thank you. So even though you have a beautiful day, we're going to practice doing some exercises inside. But first we need to work on 2 guidelines for how moderate is moderate intensity. So what we're going to use for moderate intensity is our heart rate. So let's practice along with how to find your heart rate. So Nadine, I'm going to ask, can you find your heart rate, which is finding your pulse on the side of your neck? Do you feel that pulse? I do. Okay, great. So at rest, and I'm going to use my timer here on my phone so we can figure out what is your heart rate. So we have the stopwatch on the phone, and we're going to count how many beats do you feel in a 15-second period of time. So we're going to start now. Ready? Start. So what we're going to do is take 15 seconds. And so with your number for 15 seconds, we're going to be able to do some quick math to be able to figure out what is your total beats in a whole minute. So this is now 15 seconds. Stop. What number did you have? 16. 16. So to get the time for 1 whole minute, we're going to multiply that by 4, or to do easy math, we'll double it once, which is 32, and then double it a second time, which is 64. Oh. So 64 beats per minute is your resting heart rate. So that's what we're using as our baseline to start. Now, for moderate intensity, we need to figure out how high we're going to get that heart rate. So a formula that we use is 220 beats per minute minus your age. So how old are you? Do you mind telling us?
Oh, no, you didn't ask her to tell us her age.
I'm happily 53. So 53. I'm 53 also. So we're going to use that number. This is the guideline for myself. So 220 minus 53 is 167. So your maximum heart rate that you should ever exercise at is 167 beats per minute. So when you're taking your pulse, 167. So that's the maximum. But what we want people to do is be able to exercise at a moderate intensity. So moderate is going to be about a half to 0.6 of that number, 167. So thankfully, you're at the right age and the right number that the math works out very easily to be 100 beats per minute.
Oh, wow.
Thank you for the easy math for today's lesson. So moderate intensity for a 53-year-old person is going to be 100 beats per minute. Or, as we did the pulse for 15 seconds, is 25 beats. So aerobic exercise is now going to be, how can we get you to sustain 100 beats per minute for what we're going to have is our guideline 30-minute period of time, or whatever period of time that you used in your menu to exercise for this session. So are you ready to go?
I'm ready.
All right. So we're just going to start with what can you do in your living room. Let's try marching in place. So marching in place is great. You don't need a lot of space. You can do this in your own living room. You can put on the air so you have enough air and ventilation, open the windows, whatever. That's great. Do you feel like you're working very hard for this exercise?
A little bit.
A little bit, okay. So to bring it up for moderate or more intensity, you can do more exaggerated motions. Maybe get your arms up a little higher, knees up a little bit higher. That works more body muscles. Okay. If you are feeling very energetic, you can add in a light jog. So arms come down and then you have a light jog. Okay. So we don't have our whole webinar, 30 minutes to watch Nadine jog in place, but for the purposes of this demonstration, you all get the example. So now I'm gonna have you just stop. And let's go back to checking your pulse again. So we'll break out our stopwatch and our timer and identify 15 seconds of time frame. So let's go again, start. So we're gonna count again 15 seconds. So we're at 15 seconds. We are going to see if the number is over 25 or 100 beats per minute, that means she exercised too high intensity. Stop. What was your number?
23.
23.
Oh, wow. Got right there.
So we can bring it up just a little bit notch.
You didn't make up that number, did you, Nadine? Like, this is unscripted for those who are watching. You didn't make that number up, did you?
I did not make up the number. It was legitimate.
So for that amount of intensity of exercise for her with moderate intensity would be good. If she could maintain that for her exercise session, like we said, if you're going to do 10 minutes, do that for 10 minutes, multiple times in the day. The magic number is to get up to 150 in the week. We're in your living room. You can do this while you're watching the evening news or whatever show. Maybe you just start with doing it during 1 or 2 commercials and work your way up to your whole program. So that's your aerobic intensity, and that's aerobic exercise. One other thing I wanted to say was we showed that picture of the liver in the beginning and where it sits in the body. Just above the liver is the diaphragm. The diaphragm is the breathing muscle. So when you're doing aerobic exercise, you're actually getting deep breaths and you're massaging that liver up and down, up and down. That helps to decrease the inflammation and decrease some of that fibrosis. So not just the metabolic, but the actual physical massage of aerobic activity helps the liver to function better. So that's our aerobic exercise. Are there any questions about aerobic activity while we set up for the strength training part?
Do you have to sweat for it to be aerobic?
No, it doesn't have to, you don't have to sweat. It's really just about how intense your heart rate is. Sweating could be a demonstration of your intensity, but it also could be a demonstration of how cold it is outside, how warm it is outside, how warmly you're dressed, etc. So sweating is a little bit of a gauge, but not the only factor.
Awesome.
I do have a question.
Yes.
Sometimes the patients that I see have difficulty with joint pains and other things of that nature. Are there some modifications that you could provide for aerobic exercise for those patients?
Thank you. I'm glad you asked that question because we have a chair here. So you could do the same thing if you could have a seat right here. And so you might not be able to do your whole body weight with marching in place, but you can march in a chair just like this. This takes the pressure off of the joints and you can get your arms going overhead and you're still getting the physical exercise, but not as much pressure on the joints. Excellent question. Same modification as far as, same recommendation as far as checking your pulse before or after or during, and you would change your modification. You could still go higher or more exaggerated with the arm movements or keep it low range of motion to modify the intensity.
That's awesome. Thank you.
Thank you. Okay.
Do
So are we ready to move on to the strength?
Well, I had one more question. Do we need
Yes.
to add like resistance bands or anything to the aerobic exercise? There's been at least one study showing resistance training is just as effective as aerobic training in MASLD. So what are your thoughts about that?
Yes, so we are going to add resistance training. And you can see here, we have a lot of variety of things that you can use in your house for resistance training. You don't have to use fancy weights. We have 1 liter water bottles, which are about 2 pounds. So you could do we're going to get into more specifics with strength training, just doing resistance training with lifting, such as that. Or if somebody wants to combine, you could do your aerobic marching in place with the weights, and you have resistance plus aerobic.
Okay.
All right? Excellent. Okay. So we're going to do a couple of strength training exercises. And so we're just going to keep these 2 pound weights, but we can see here that using something like your laundry soap is about 4 pounds. This is an exercise equipment. And even using something like your spaghetti jars can also be exercise equipment. So you can be creative with whatever you have around the house to work on resistance and strength training for exercise.
I do want to interrupt here for those watching. Those soda bottles, we would assume that you would empty the soda out and not drink the soda before using them for your exercise, because sugar is not the greatest for this condition.
So she is actually using 0 calorie, 0 sugar, 0 caffeine, 0 sodium water bottles.
Perfect. I just wanted to make that note.
Yes. And ideally, you would want to use, thank you for the safety warning. Ideally, you want to use flat water because we don't want to be shaking up carbonation and then have a big mess after we're done our exercise.
Great point.
Great point. Okay. So for strength training, I'm going to have you stand against this wall right here. And so for strength training, we have, we're going to break it down to upper body and lower body exercises. So with upper body, you want to think about some big muscle groups like your biceps, your deltoids, your lats, etc. So what I like is this exercise where we can just think about doing bicep curls and then press overhead. Good, just like that. So whatever weight works for you, curl and up. And so she's working on the biceps here, the deltoids, the lat muscles, and down we're working on tricep control. What you see is she's turning because the shoulder joint, we want to be aware that the shoulder joint, we don't want to pinch and create impingement. So she's turning as a natural movement to do the press overhead. So our recommendation is doing 8 to 12 repetitions and feeling that it should be feeling moderate intensity. Is this weight easy for you? Yeah. Yes. Okay. So for our demonstration here, she would want to use a higher or heavier weight to make it more challenging for her because she can do these ones with ease. If we switch to a different exercise, I'm going to have you lift straight up ahead this way and then lower down. And now do something like, call this a wall angel, like snow angels, but we're doing it against the wall. Sorry.
Oops. Yikes. Careful over there.
Okay. So straight ahead, alternating, and then out to the side, alternating. Fantastic. So again, working on shoulders, upper body exercise. And even though we haven't changed the weight, we're changing how far away the weight is from the body, which makes it more challenging than when we were close to the body with the previous exercise. Is this one more challenging for you?
Yes.
Yeah. So for the previous exercise, this 2 pounds in each hand wasn't too difficult. For this one with a longer lever arm, we're challenging you a little bit more. Okay? So that's what we call resistance training with weights. Okay. We could use the body weight for resistance training, and we're going to do the classic push-up. So let's do 3 different versions of a push-up. So a wall push-up is a nice, easy way to start with push-ups. So go ahead, do a push-up, lower your body to the wall, and then come back. Again, we're working upper body, biceps, triceps, your shoulders, your delts, your lats, these large muscle groups. And of course, in the front, the pec muscles in the front. So again, 8 to 12 reps is what we're looking for one set. And as you progress to 2 to 3 sets, you're going to get up to 36 different repetitions. How are you feeling with those wall push-ups? Great. Is that moderate intensity, light, or easy for you? Moderate. Okay, great. So now, to make it more of a challenge, we're going to switch over. Let's switch places here. And now get you a little bit closer down onto, and use the couch. So this is the arm of the couch. And so she's got nice form straight. This makes it also a core exercise. And now go ahead and lower towards the couch there. And same muscle group. It's just a little bit harder because you're going down a little bit further and working up against gravity. Is this more challenging for you? Yes. Okay.
Do core exercises have anything to do with like visceral fat eradication, or like I don't know, just a question I have.
It's a good question. The core is your abdominal muscles in the front, the back muscles, the pelvic floor muscles, and also what we already talked about earlier, which is the diaphragm up top. All of that is the core. It's got side, top, and bottom. All of that's the core, and keeping a good, strong core in the center. Have you gotten to 8 to 12 reps? Sorry. let our model rest.
Yeah, I know, overachiever.
So yes, the core exercises do help to make sure that you have a nice upright and center and balanced front to back, and that does help with your posture, strength, and metabolism. So, are you ready for the next challenge with the upper body closed chain, body weight resistance for upper body? So the last one is going to be now getting down onto the floor to do the push-up on the floor. So you can do this with feet on the floor, like your toes, or you can do a modified version with knees on the ground. And now we're fully going against gravity to do, again, 8 to 12 repetitions. Is this impressive or what? Wait,
Yeah.
Very
impressive.
Okay. So that's upper body resisted exercises.
Dr. Loretta, do you think these exercises are accessible to many of your patients in clinic?
Absolutely, and it's so nice to see that you don't even have to go to the gym. You can do it in the home, like you were showing us. So I think these are really good tips for people to do it. Like you said, if you're at home watching TV, you can start doing these exercises, and it doesn't require going to the gym and other complex things. So yeah, great.
Great. So the last set is, we don't want to ignore the lower body. That's what carries us through space and through life. So we're going to just do 2 exercises for the lower body, which comes a lot of muscle groups. So our upper body, we get with 1 or 2 exercises, we can get a lot of different muscle groups. And now with the lower body, same thing. So we're going to start with a basic squat. So we're going to use a chair. And you can have a seat here. Okay. And so our squat is really going to be standing up and down. So go ahead, up and down. So when you go down, that's actually a squat. But when you sit down in a chair, you get to rest in between each one. So this is actually a squat. So anybody who says they can't do squats, they stand up and sit down out of a chair. Okay. Again, 8 to 12 reps is a good exercise for us to do. So if this is too easy, we can now make it more challenging and then take the chair away. So now you can just go right into a squat. How's your balance with this one, Nadine?
I'm doing okay.
Okay.
You're doing great.
So in between sitting in a chair and doing a squat like this, we can use a little bit of support. And this is an in-between version of doing the squat. So it's a little mini squat. There's many ways to do squats. We talked about with diabetic, we might have some balance challenges. So how we want to challenge the balance to work on the balance system and the strength system is maybe knees together, feet together, and then so you can squat that way. And you're going to maybe just do fingertip touch on here so that you're using more of your legs and not your upper body for grasping on this way. So this is body weight resistance, up and down. Okay, I'm going to show you one more thing with you back on the chair here. So have a seat back on the chair. And to make it more challenging, we can put this band around your feet. And this is one of these ways that we can do upper body and lower body at the same time, where you are going to hold on to this band, stand up, and then lift. And now sit down. So now we have a combination of upper body and lower body, all in one exercise for body weight resistance, plus adding some exercise bands. These exercise bands are very easy to find in an exercise store, and you can order them online as well. So that's one exercise for body weight resistance, and then the other is just working on the calf. So I'm going to take this exercise, this band away from you here, have you stand up, and again we're going to let you hold on to the chair and do toe elevation, up and down, on your toes, heels, and go up. And so this challenges your balance. If this is to take it to the next level, one leg at a time. Sorry, one leg at a time. So we're working the calf, the foot muscle. These are the muscles that help, again, propel you through space. And then when you're doing your walking in place aerobic, you have more leverage here. If you have any foot and ankle previous injuries, you might notice that one side is difficult to do than the other side. Bunions, hammer toes, Achilles, ruptures, any things like that, you might notice that one side might be different than the other, and that's okay. You have a still challenge one side to the other side. And then, of course, no hands, like she already started to demonstrate. No hands, again, would even now be more challenging for doing these exercises. What do you think?
Feels great.
Okay, great.
Doing such a great job.
She's doing a great job. Thank you very much. I wanted to just, so one more exercise with the resistance band. And so I'm going to have you go ahead and put that around your knees. And then so with our exercises, we targeted the front and back muscles, but we can't forget about our side muscles. So those muscles that we need to go side to side, which sometimes you need to do, like you're walking down the street and you need to pass somebody in the hallway. We need to get these hip muscles on the side working. So a band around the knees and just doing some side stepping with resistance helps to target your lateral hip muscles for rotation, abduction. So walking side to side with the resistance band is one option. You can put the band around the ankles. That makes it even harder. Higher up on the thigh makes it easier. And then if you could turn around sideways, and then you can now also work on more of your hip muscles. The gluteus maximus, this buttocks muscle, is really the muscle that we need to do that standing up, that squatting. And so a different way to exercise this muscle would be to now walk backwards with the resistance band. And then forward as well. Okay. So the option to do this, again, if people have joint pain and they are having difficulty with the walking exercises, any of these exercises can be done in sitting. resistance band around the knees, and then you can just practice going out side to side, one leg at a time, or both. So we have the perfect, thank you. And so you would want to work up to 8 to 12 repetitions for each of these exercises. And once you get to 8 to 12 repetitions, multiple sets to really build up your endurance, about 30 or so repetitions for each of these exercises. So those are some examples of some simple resistance for upper body, lower body exercises that you could do. We threw in a little bit of balance challenges in there as well for folks that really need to be working on their balance and help with their kind of proprioception, we call it, through the feet to help them with being more safe out ambulating and walking in the environment.
That's really great.
Yeah.
I feel like there's so many things to pick and choose from too. So
Yes.
super helpful.
Okay. Do you have any questions about any of the exercises that you went over? Do you think that's something you could practice?
No, I think this would absolutely be something I could incorporate 3 times a week.
Excellent. Thank you.
Nice.
Thank you.
Thanks.
Thank you both. That was very helpful to see it. So for those of you watching, hopefully you found that accessible as well. Really using your own home and things in your home to help you achieve 150 minutes a week. Did I get it right, Dr. Dugan?
Yes, 150 minutes per week.
All right, awesome. So we're back together, all of us now. I'm gonna do a little bit of a wrap up. There's some questions that came in through the registration process, and we don't have time to get to all of them, but I did pull out a few, so wanted to cover those in the last few minutes that we have with one another. But first, a big thank you to Dr. Dugan for bringing your expertise here. That was just fantastic. First question goes to Dr. Moretta. This is really a very common question, I would say, but I wanted to pull this forward. People really still want to know, if they get this diagnosis and they do all these things, can the disease go away?
Absolutely. I've seen many of my patients with MASLD who have complete resolution of fat and fibrosis in the liver, even at stage 3 fibrosis stages. So this is reversible. It does take change in the lifestyle, and we have medications to help as well, but it is a reversible disease, especially in the earlier stages.
And this would be like kind of a lifelong change, or is it kind of one and done? You change once and you never have to worry about it again?
It's absolutely a lifelong change, and that's why we recommend slow, sustainable changes and not rapid changes that are not sustainable. So this is actually lifelong. If people fall off and regain weight, then the fatty liver can progress and get worse or come back, and so it is a lifelong disease. So,
okay,
long haul.
Thank you. A few questions on this topic as well, some by way of storytelling, and I've definitely heard these stories from my patients too many times. So to you, Dr. Span, if people are worried that they might have this condition, or maybe they have risk factors for this, they want to try to advocate for being tested, what should they tell their doctors or ask their doctors about?
Absolutely. I think, and at any point, if you have any of these metabolic risk factors that we discussed, if you have obesity or overweight, if you have diabetes, or even the prior period to diabetes, pre-diabetes, high blood pressure, high cholesterol, any of these things, family history as well. If you have any of these things, always ask your doctor to screen you for liver disease. What that can look like is you can get blood tests looking at your liver enzymes, blood tests looking at your liver function, blood tests looking at how well your blood clots, because your liver does affect that as well too. And those numbers can be helpful to guide whether or not you need additional screening, or if you're at higher risk for having that scarring in the liver. Other tests that can be done to kind of look for this include ultrasounds or what we call elastography studies, which is just a fancy word for us to be able to say how much scarring do you actually have in your liver or not. And those are always recommended. We even have recent recommendations for patients who have diabetes to go directly to that step where we're looking for scarring in your liver as well. So always be, your best advocate in that regard. I think our providers try to do our best in doing so, but the best advocate always is the person themselves. So we always recommend if you have any of these concerns, bring that up with your doctor so that we can get you screened.
And those of you watching, you may not know this if you don't know our organization or haven't followed us. We actually developed a resource for just this reason. So if you go to our website, www.blackandgastro.org, we've developed something called the Doctor Will See You Now campaign. And in that is a guide that you can go through and answer questions. And at the end, it will provide you with a list of things that you can take with you to specifically talk to your doctor about. And it's individualized. So we hope you take advantage of this resource. We designed it for all of you. So Dr. Dugan, this question, I can't tell you how many times I've heard it, and it definitely came up in the registration. People don't want to necessarily have to do all the things. So if you had to pick exercise or diet in terms of changing behavior, which one should we pick?
Oh, that's tough. Oh, that's a tough one. I will say it really does start with what you're putting in your mouth. It really does. You can't exercise if you're malnourished. You're going to kind of put yourself in a different kind of metabolic disorder. So it really does start with what you're putting in your mouth. And so we really do need to be mindful about how we're nourishing our bodies. It's not just about eating, it's about nourishing your body. And what is your fuel? What is the fuel doing for you? Is it fueling your body, or is it actually working against you?
But exercise is still necessary. Right?
Exercise.
You don't want people to leave saying they can just leave it behind.
We can't leave it behind. Exercise is necessary. And as I said, even if you're doing 10-minute bouts, or if you decide that you're going to do one squat every hour, or you're going to take the steps instead of taking the elevator one flight, all those things add up to your body being good thermogenesis and actually burning energy and having your metabolism work for you. So extra steps, all those tips that people say, park one row further away when you're going shopping. As I said, take the steps instead of the elevator. All those things actually do add up to 150 minutes per week.
Fantastic. Thanks for that. And now we have no excuse because you gave us a lot of ways we can get it in. So just in closing, I want to say a big thank you again to all of our panelists for helping us understand liver health and biology and what's available to keep our livers healthy or improve our livers if we have liver diseases. And just for talking about this topic in particular, MASLD. Not a lot of people have heard even the name change, so I'm really excited to bring that to you all today. We talked about how to diagnose it, how to treat it, and how exercise itself is important for the therapy of this condition. And for those watching, please do talk to your doctors and other healthcare professionals to ensure you are discussing how to get screened for liver diseases and how to get treated if you have a liver disease. And to find out more information about our organization, find us at www.blackandgastro.org or on social media at Black and Gastro. This recording will be available soon on our website and on the GLI website. Finally, ABGH has so much planned for all of you to continue this conversation in our community. Our network of Black doctors is growing, and we are excited to bring you more. Follow us and stay tuned for our next event. Thank you.